Hello, my name is Trent Garwood, and today I'll be talking about drug resistance as a public health issue. I'd just like to begin by acknowledging the traditional owners of the land on which we live, work and study, which for me is the Yirraganji and Jabbergai people of the northern beaches of Cairns, and to pay my respects to Aboriginal and Torres Strait Islander elders past and present. I'm an infectious diseases physician, and as you can see there, I've worked in a number of roles looking at drug resistance, both at our local hospital in Cairns, at a state level as the director of the Queensland statewide antimicrobial stewardship program, and at a national level as a medical advisor to the Antimicrobial Use and Resistance in Australia, or AURA program. I'm not working in any of those roles at the moment, and I'd just like to point out that this talk is given in my personal capacity and not as a representative of Queensland Health or Cairns and Hinterland Health Service. I've got no conflicts to declare other than my previous roles. Today I'll be talking about the burden of drug resistance and drug-resistant infection and the impact that it has on medical care. I'll be talking about ways that we can reduce drug resistance, about what's happening with the antibiotic pipeline in terms of new drug development, and talking about what an antimicrobial stewardship program involves, and touching on some of the issues of, I guess, how this relates to public health as opposed to predominantly as clinical medicine. This quote just goes to highlight that drug resistance is nothing new. It's a story about a patient who is feeling a bit unwell with a sore throat, presumably due to a virus, who gets some penicillin and takes it, but doesn't take enough, which then promotes the bacteria living in his throat to become resistant. And then when his wife gets pneumonia and is treated with penicillin, the streptococci that they share are now unable to be treated, and the initial patient's wife dies. So who is primarily responsible for her death? Now, this might seem like a fairly standard sort of, I guess, drug-resistant scare story, but in fact the quote is from Alexander Fleming, who was the discoverer of penicillin, which he gave this quote in his Nobel Prize acceptance speech in 1945. So what we know is that drug resistance has always been around, and that it has always been an issue, and that it will continue to be an issue. But although it's getting a bit more press in recent times, the understanding of the threat of drug resistance is certainly nothing new. In fact, you can see some quotes here from some very famous and important people. Ban Ki-moon, former Secretary General of the United Nations, says that drug resistance is a fundamental threat to health and development. So not just focusing on the health aspects, but also the economic and development aspects of global society. Dave Sally Davies, who's the person in the bottom picture, was appointed the UK's Special Envoy on Drug Resistance, described resistance as being a catastrophic threat to healthcare. And Margaret Chan, who was the former director of the World Health Organization, gave in a major speech to the World Health Assembly a warning that we were potentially heading to a post-antibiotic era, which is a way of saying that we will live in a time when antibiotics will be completely ineffective at preventing infection. So the recent interest in drug resistance as a global health problem sparked this review called the O'Neill Review, or the Review on Antimicrobial Resistance. Now, Jim O'Neill is not a doctor or a public health physician or a public health scientist. In fact, he's not a scientist at all. He's actually an economist. He is the person who coined the term BRIC countries for the sort of the middle income developing countries. And he, in fact, said, "Why are you getting me to chair this review? I don't understand anything about science or bacteria." And by the time he'd come to the end of chairing the review, he appreciated just what a huge, not only health problem it was, but also an economic problem. And you can download the report in full at the website amrreview.org. You can see there. And some of the headline figures are pretty scary. You can see there that there's a modelling that suggests that by 2050, drug resistance alone will have been responsible for the loss of billions of lives and trillions of dollars worth of deferred economic activity. I'll come back to some of that economic sort of way of presenting drug resistance a little bit later on, but this, I think, is a much more practical way of thinking about it for clinicians. I think the public don't entirely recognise just how much of what happens in hospital, even non-infectious medicine, is entirely dependent on the use of antibiotics. So chemotherapy, for example, very unusual for people who get aggressive chemotherapy for acute leukemia not to end up with a life-threatening bloodstream infection, but many of them will also end up on prophylactic antibiotics throughout the course of their chemotherapy to reduce the incidence of these serious infections. Almost all patients in intensive care who are critically ill will go on to develop some sort of healthcare associated infection, and antibiotics play a critical role in treating these infections to allow people's bodies to recover. Joint replacements all receive prophylactic antibiotics and would be much more difficult if antibiotics were administered. Things like transplant medicine and even something as simple as a transrectal prostate biopsy, the rate of life-threatening sepsis from a transrectal prostate biopsy is very significant. So the graph there is from a study in The Lancet in 2015, which again was a modelling study rather than a data study. But what it shows is the number of additional deaths that would occur in healthcare if antibiotics effectiveness were reduced by particular percentages. So the darkest line is a 10% reduction. The next darkest red is 30%. Then the sort of the mid peach color is 70%. And then the palest red is if antibiotics were completely ineffective. And you can see for things like colorectal surgery, where it's always contaminated surgery because you're transecting the bowel and the operative field becomes contaminated with feces, that just routine management of bowel cancers and other colorectal conditions would result in an additional 15,000 deaths per year if antibiotics were ineffective. And even with a more modest 30% reduction, we would be looking at 5,000 to 6,000 additional deaths per year. And then chemotherapy and hip replacements would all additionally result in additional avoidable deaths just due to drug resistance. One of the key ways through which drug resistance increases people's risk of death is the management of sepsis. So we know that the biggest determinant of survival in sepsis is the time to receiving appropriate antimicrobials. And if your pathogen causing your sepsis syndrome is resistant, then it's likely, or possible at least, that the antibiotics that you're given initially will be ineffective. And so the longer you go on until you receive appropriate antibiotics increases your risk of poor outcomes. If you have a resistant infection, it increases your length of stay, and that's assuming that you survive and that you don't succumb to your sepsis syndrome. And it's also important to know that resistant infections cost significantly more than treating susceptible infections, because we have to use different or second line or more expensive antibiotics, or longer courses, or through the incurring additional costs because people are staying in hospital longer. So drug resistance is bad not only for individual patients, but it's also bad for the health system as well. An issue in Australia is that we have relatively very high use of antibiotics. The graph on the left you can see is doses of antibiotic per 1,000 people per day, and that Australia is leading the world on this table. This is comparing Australia to countries with similar sort of health systems, and you can see that our use is somewhere around double that in Sweden, and is almost quadruple the rate of usage in the Netherlands. The graph on the right shows the same sort of figure, doses per 1,000 people per day, but looking at outpatients, so community use in 2019. And you can see that again, Australia is sort of well and truly in the top 25%, and that's 23 doses of antibiotics per 1,000 people per day. Before I talk too much more about drug resistance and the harms of antibiotic overuse, it is just worth taking a step back and thinking about this from a public health perspective. And Mark Mendelsohn, who is an infectious diseases physician in South Africa and really has sort of done most of the work in South Africa's development of antimicrobial stewardship programs, gave a talk in Melbourne a few years ago where he said that it's very important to keep perspective and remember that globally more people die from lack of access to antibiotics than through their excess. And so around the world, more than 800 million people lack access to safe drinking water. 2.5 billion people don't have access to efficient modern sanitation services like toilets, and that overall we lose 272 million days worth of school amongst children because of waterborne diseases like gastroenteritis. So while drug resistance is a big problem, there are other issues that we need to address as well. For this subject, I've also given a talk on drug resistance, and of course you'll remember that, on infection control. And one of the key ways of preventing drug resistance is preventing the acquisition of infection in the first place. And so addressing these issues that promote the likelihood of getting infection, so lack of access to clean water and what have you, also reduce the impact of drug resistance, because one of the challenges is, as I'll show on the next few slides, is that many of the countries that have the most resource challenges in their health system also have very high rates of drug resistance. So they're kind of getting a double whammy, that they're more likely to get infected, and then they're more likely that their infection will be caused due to a drug resistant organism. The next couple of slides feature some graphs from a paper that was co-authored by Peter Collignon, who's an infectious diseases physician in Canberra, and who has been one of Australia's leaders on drug resistance, was one of the authors of very early reports in Australia in the 90s about the threat of drug resistance. Now, what the graph shows on the left is essentially a heat map of drug resistance. And so the green countries have relatively lower resistance, moving through yellow to orange to red. And so you can see there that Australia, comparatively, despite our very high antibiotic use, is actually doing relatively well. And that in general, the developed nations, so Scandinavia and the UK and much of Europe and America, North America, have relatively low rates of resistance, whereas the developing world, so Russia, China, India, the Southeast Asia, and some of the African countries, many of which we don't have data for, are the places where there is more resistance. Now, the graph on the right is a similar heat map, which shows the, a marker of the development index of the country, so how well in place their global infrastructure is. And so you can see that there's actually relatively, particularly in Africa and South Asia especially, a lot of overlap between places that have poor infrastructure, poor health infrastructure, and rates of drug resistance. One of the other things that's interesting about this study is that it also links the likelihood of resistance to, the quality of governance in your country. So the degree of corruption in government, the appropriateness of sort of governance channels, and you can see the correlation is not quite as good, but that there's a strong trend to countries that have higher problems with drug resistance having less robust government systems. Now, whether that's cause or effect or is sort of not well described by this paper, it's just correlation, but it certainly highlights that it's going to be a greater challenge to respond to drug resistance in these countries because they lack sort of good, efficient systems to be able to adapt to drug resistance and to mitigate it through I guess a whole, One Health sort of strategy. We consider that there's really four pillars of response to drug resistance. The first is the development of new antibiotics. So we have new agents that we can use that hopefully the pathogens aren't resistant to. We have better use of antibiotics that we already have, which is what people generally consider to be antibiotic stewardship. As I alluded to before, infection and prevention and control is very important in preventing drug resistance because if you don't get an infection, it doesn't matter whether it's resistant or not. And better diagnostics, both in terms of assessment of resistance, but also rapid diagnosis of infectious syndrome. So for example, if you come in with symptoms consistent with an upper respiratory tract infection, you have a point of care test that confirms that you have strep pyogenes in your throat, then perhaps we can better target antibiotics for people who have legit strep throats rather than just sort of saying, oh, well, either it's probably viral or giving everybody penicillin because we're concerned about rheumatic fever or post-strep GN or those sort of things. Just a point here too, I'm talking a lot about antibiotics. Most of the significant resistance is in bacteria. So that's antibiotics are antimicrobials that work on bacteria, but resistance in viruses and fungi and parasites is also important as well. However, it's not as at the same scale as bacterial resistance. And so we do tend to focus on bacteria and antibiotics rather than, I guess, the more broad term of antimicrobials, which includes all of the different groups of pathogens and the drugs that treat them. But as I'll talk about a little bit later, I'm not a huge fan of the term antimicrobial resistance. A quick slide on the development of new antimicrobial agents. It's a quick slide because there basically is none. There have only been 3 novel classes of antibiotics developed in the last 20 years. There's few truly new drugs. Most of them are sort of tweaks or modifications or variations on a theme. And many of the antibiotics that we use in clinical practice now were actually developed more than 50 years ago. The graph there you can see is the number of new agents registered by the US Federal Drug Administration in sort of year bands, in 4-year bands, and you can see that it's dropped right off. There have been a few new ones in recent years, but again, they're usually these modifications on a theme. Now, a big part of the reason that drug companies are not investing in the development of new antimicrobial agents is because of just purely financial issues. So it's a very poor return on investment to spend hundreds of thousands or millions of dollars developing a new antibiotic that in the very, very, very best case scenario, people will take a 5-day course of for their resistant urinary tract infection and then will hopefully never need to take again. And that's assuming that you don't have antibiotic stewardship doctors saying, well, we've got new acillin, which we're not going to let anybody use ever because we need to keep it up our sleeves for very sick people who have very resistant organisms. And so the drug companies pour all this money into making a new antibiotic that then stewardship principles stop people from actually using. And that's part of the reason that we really need to think differently and about the funding of drug development. So, without going into too much detail, drug companies essentially invest an enormous amount in research and development costs looking for new molecules, and then when they get a hit, they say, this is awesome, this is the best new thing, we're going to sell it for $1 squillion, and then they make back all of the money that they spent developing not only that drug, but the 50 other drugs that they spent some research funding on that didn't end up being safe in humans or effective or had problems for whatever reason. And clearly that model is not going to work for new antimicrobials. And one of the recommendations from the O'Neill report was to look into new ways of drug funding, so public-private partnerships or incentive payments from governments to drug companies to encourage them to still try and develop new antimicrobial agents where the previously sort of long-standing financial incentives for drug development don't work. As I said, infection prevention is really important because if you don't get an infection, it doesn't matter whether your organism is resistant or susceptible, because you don't need treatment because you don't have an infection. So attention to all of the different parts of infection prevention, and again, I'll refer you to my other lecture, including vaccination, hygiene, as I alluded to, for particularly with a focus on the developing world, hospital infection prevention, and simple things like using oral therapy where possible, so there's no possibility of getting an IV line infection, and also, not just focusing on hospitals, but preventing infections in the community through, for example, prevention of bacterial STIs like gonorrhea and syphilis through the use of condom promotion. Better diagnostics is really important. As I said, that can include simple things like appropriately collecting cultures before you start people on therapy. The example we commonly use for this is blood cultures in the emergency department. I guess the argument against doing blood cultures in the emergency department is they say, well, it's not going to change our management because we're going to give them broad spectrum empirical therapy anyway, and it costs money, and we then have to worry about following up the results, and what about the fact that we get false positive results from our blood cultures. So there's all these reasons against it, but of course that is fine if you are considering only the patient's journey while they're in the emergency department. Cultures before antibiotics for the inpatient part of a patient hospital stay can significantly change management. For example, if you find a susceptible organism, that can allow you to narrow their therapy down. If you one of your diagnostic investigations in the emergency department comes up a couple of days later with an alternate diagnosis, you can then stop the antibiotics that were being used altogether, whereas if that stuff's not collected, you just have to keep playing it by ear or using clinical judgment. As I said before, rapid testing has a role, particularly in primary care and potentially also in resource-limited settings. So, for example, in terms of STIs, we know that the rate of diagnosis of chlamydia and gonorrhea in people presenting to sexual health clinics with dysuria is not very high. It's probably of the order of 25 to 30%, and that's if you're symptomatic. So if we are then able to get someone to give a urine sample in the clinic, to go take it out the back, to put it on a machine and say, yes, you have chlamydia, we can then give them their azithromycin and send them on their way, not have to worry about getting them back for further treatment, but also to be able to avoid giving treatment to all of those other people who previously we would have said, oh, well, you've got symptoms, so we might as well give you empiric treatment today. And finally, just a plea for those of you who are clinicians to remember that taking a good history and performing a good directed examination is actually very useful in making a diagnosis and can significantly help narrow down what's going on, and giving therapy that's at least directed against a syndrome rather than, oh, they're just sick and we don't know what's going on, is as an important part of antimicrobial stewardship in itself. So for the rest of the talk, I'm going to speak about antimicrobial stewardship specifically, which is the program that we do to better manage the use of antibiotics in hospital and in the communities. And I'll go through the different aspects of stewardship programs one at a time. The concept of stewardship's been around for a long time. The first sort of study that people generally quote was a study by McDougall in 2005, which defined stewardship as an effort by a healthcare institution to optimize antibiotic use or antimicrobial use in order to improve patient outcomes, ensure cost effectiveness of therapy, and reduce the adverse effects of antimicrobial use, including resistance. Certainly in Australia, it's now a requirement of hospital accreditation, and there is also some discussion of the role of stewardship in primary care, although I'll touch a little bit later on how that's a bit more difficult. If you ask prescribers what a stewardship program involves, they will generally say it's about not letting us use meropenem. And formulary restriction is part of a stewardship program, but it really is only a minor part. And there's many other things that sort of go into the running of a stewardship program in hospitals or in elsewhere. Prescriber education is a big part, as is the education of patients and the community. contributing to the development of hospital or elsewhere guidelines. There's the hands-on stewardship, if you like, so getting out onto the wards and reviewing the drug charts of people who are receiving antimicrobials, and then speaking to the prescribers and providing them with direct feedback. Formulary restriction does have a role to play as part of a stewardship program, but it's not the major part, because by giving people a more constrained number of choices, you're then able, hopefully, to drive their prescribing more in the direction that you would like it to be. And for particularly important antibiotic agents, then requiring pre-approval, so speak to the infection team before you put people on meropenem, for example, is another way of getting involvement from expert clinicians up front to hopefully provide assistance with diagnosis, and also making sure that the use of the most important antibiotic agents is done judiciously. There's now very good data showing that stewardship programs work. We know that being seen by an infectious disease physician improves your clinical outcome if you have a Staph aureus bloodstream infection, and by improving clinical outcomes, that means reduces length of stay, reduces mortality, reduces the likelihood of readmission to hospital, and ensures more cost-effective care. The concern from clinicians, particularly critical care clinicians, about stewardship programs is they won't let us use the antibiotics we want, and then people will die of sepsis. And so we now have very good and very long-term data that shows that that's not an issue. You can reduce the antibiotic use in your hospital without an increase in adverse patient outcomes, including deaths from sepsis, including negative infection outcomes, and that the reduction in antimicrobial use is greatest in broad spectrum agents, where there's this concern, well, if we don't hit them broad when they come into ED with their sepsis, then they might die. But we know now that patients do not die of sepsis because of antimicrobial stewardship programs. We also know that post-prescription review and feedback actually improves the quality of prescribing done by junior medical staff in hospitals. It means that more of the scripts that they're given are appropriate. It means that overall there's fewer treatment days with antimicrobials, and as I said, that overall clinical outcomes are very similar. So stewardship improves prescribing, improves individual patient outcomes without causing health system harm. So I guess that's the bogeyman that, if you like, that stewardship had to sort of labour under for the first number of years, that it was a thing in hospitals. It was, you're kind of public healthing our individual patients. You're going to give my patient less good care to ensure that there's less drug resistance around the place, and that's really not what we're about. As I said back on the definition slide from the McDougall paper, stewardship is actually about improving individual patient outcome in terms of their outcome of their infection, so their short-term clinical outcome, if you like. It's about improving or reducing their likelihood of having adverse antibiotic effects, either as a direct treatment effect, so you're on antibiotics for longer, so you're more likely to get C. diff, but also about reducing their risk of developing drug resistance, because we know that every dose of antibiotics increases your risk of getting drug resistance. And then that also reduces the population risk of that individual patient going on and spreading that drug resistance to other individuals in the community, in their family, into the sewerage, and out into the environment. The first thing that you hear as a stewardship clinician, especially back from the specialised teams, whether that be haematology or oncology, or the renal physicians or peds patients or plastic surgeons saying, but my graft, transplant patients, geriatricians, our old patients don't react the same way that young patients do. Absolutely every clinician group in the hospital says that their patients are special. And when they say that their patients are special, what that means is we don't want to follow the guidelines because we're worried that our patients will do poorly. Kids are not little adults, old people are not like young people, transplant patients are on lots of immunosuppression, dialysis patients don't mount a febrile response. Every single individual clinical group has a very specific and, valid in their mind reason that guidelines shouldn't apply to them, because their patients will do more poorly if they don't have their infections managed optimally. However, what we know is that the factors that are associated with the likelihood of having drug-resistant infection is the intensity of healthcare that you receive. So renal patients are much more likely than cardiology patients, say, to have drug resistance, because renal patients are in hospital 3 times a week for dialysis. But the second thing that increases the likelihood of getting drug resistance is the duration of antimicrobial therapy that you receive and the broadness of the spectrum of that antimicrobial therapy. So, in some way, these patients are more likely to have drug resistance. However, by assuming that they do and managing them with broad spectrum, longer courses of antibiotics, all the rest of it, you're actually increasing their subsequent risk later on. And what we know is, particularly in Australia, that we have very, very good prescribing guidelines, and that the guidelines are actually written to have some, risk tolerance for the likelihood of having a drug-resistant infection, and also to cover a range of options that will include common and clinically important resistances. And so if you prescribe according to the guidelines, so not my patients are special, therefore I need to ignore the guidelines, but if you follow the guidelines, your patients actually do better. They have a greater than 50% reduction in their 30-day mortality, which was highly statistically significant. They have a greater than 50% reduction in their in-hospital mortality, which was highly statistically significant. And there was a non-significant but short reduction in their length of stay. So if your patients are special, you shouldn't not prescribe according to the guidelines. You should adhere to them even more slavishly, unless there's a good reason not to. Because we know that guideline concordant prescribing actually specifically improves your individual patient outcomes. So not only looking at individual patient outcomes, but looking at sort of system outcomes. Does stewardship actually work? Well, it does. So this is a slightly complicated graph. So the blue bars represent the incidence of cases of Clostridioides difficile diarrhea in our hospital in Canada. You can see that, so the graph shows an outbreak of C. diff in the hospital. The size of the blue bars goes up across the first sort of section of the graph. Now, where you can see the large red arrow, the infection control team instituted very stringent infection control requirements in their hospital. So anybody with diarrhea got isolated, put on contact precautions immediately. Preference for patients to be in mandatory use of single rooms for anybody with diarrhea. Preference for as many single rooms for other admissions as possible. And you can see that for about another 6 or 7 months after those very stringent infection control measures were put in place, that the C. diff outbreak continued. Now, the second part of the graph is the yellow line, which is the rate of usage of antibiotics per 1,000 patient days, particularly for antibiotics that are very prone to promoting C. diff infection. And so you can see across that first part of the graph, before and after the implementation of the infection control measures, the rate of use of those antibiotics remained very high, and the rate of C. diff didn't particularly drop even despite the infection control measures. Then during the shaded green box, you can see that the yellow line dropped precipitously because the pro-C. diff antibiotics, if you like, were much more heavily restricted. And it was then, and perhaps they were starting to drop off at the start, through the infection control measures. But overall, you can see that as the high-risk antibiotic use declined, so too then did the rates of C. diff, and the rates actually stayed low even when the enhanced infection control measures were removed, because the rate of those high-risk C. diff antibiotic use remained low. This is just a different example from a hospital that I worked at when I was a trainee. The blue bouncy line is the number of isolates of extended spectrum beta-lactamase producing Klebsiella pneumoniae in the hospital, counts per month. So you can see that they were sitting up around 10 or 12 cases of ESBL Kleb per month. Then where I've hand drawn in the black arrow was a major overhaul of the hospital's antimicrobial use policy, and you can see within a few months after that that the rates of ESBL Kleb were in sort of low single figures per month, and through the early 2000s there were many months where there were no cases at all. So stewardship definitely works at both an individual patient level, but also a prevention of resistance at a hospital systems level. Just a further example of the effectiveness of antimicrobial stewardship. One of the significant, but sometimes silent or relatively silent areas of antibiotic use in hospitals is surgical prophylaxis. Patients, even patients having day surgery, come in, they receive antibiotics in theatre for their surgery, and then they may get another dose after the surgery on the wards if they stay that long, or they just go home. But we know often that data is not as well captured because the antibiotics are recorded in different places. They might be put on the anaesthetic record rather than on the drug chart. And so there's a lot less visibility of what happens. But one of the things that we know that there is now very good evidence for is that antibiotic prophylaxis is only effective if given prior to surgery. There's a couple of particular cases where there is a recommendation for post-surgery antibiotics, for example, in thoracotomy for cardiac surgery and amputation of ischemic limbs, but the data for those indications is actually fairly weak. There is essentially no data that giving extended courses of antibiotics post-surgery reduce the rate of infection. It's very common practice, but there's no data that it improves outcomes. And the reason is because the key determinants, if you like, of surgical site infection are the concentration of antibiotic in the tissue at the time that the incision is made. So when that surgical incision is made, you need to have the antibiotic on board. So that means it ideally needs not to be given as a push as the patient is going to sleep, because it's probably not circulating to the tissues well enough. You ideally want to give it sort of half an hour before the incision is made so that it has a chance to reach the tissues where it's going to have its effect, because that is what reduces the incidence of surgical site infection. Now, people say to me, oh, but Trent, everybody who ends up having surgery is, ends up on antibiotic treatment on the ward. Now, while there's some truth to that, it's important to remember that some of those patients have separate indications for treatment. So, for example, if you have appendicitis, the antibiotics aren't being used as prophylactic, well, they were. There's one dose of antibiotics that are used as prophylaxis for the appendectomy. The rest of the antibiotics are probably being used to treat the appendicitis. So that doesn't mean automatically that any patient who's receiving antibiotics post-surgery is automatically getting inappropriate treatment. What it means is that for patients who have clean surgery where there isn't an infection that's being managed surgically, which also needs antibiotics as adjunctive therapy, then there's no indication for for post-procedure antibiotics. If there is a contaminated field or an infection or something else going on, then that can be antibiotics post-operatively can be appropriate. So you've got to differentiate in your mind surgical prophylaxis from medical treatment of a surgical issue. This is one of my just about favourite prophylaxis and stewardship papers of all time, and even more so because it's actually published in a surgical journal, not an infection journal. It's a little bit complicated, so I'll go through it slowly to explain. So what you can see is this slide is the risk of surgical site infection post-surgery. And the three different dots look at whether antibiotics are given for up to 2 days after surgery. And remember what I said on the previous slide is that we don't generally recommend any post-surgical antibiotics, but there's often a bit of wiggle room given. But 1 day to less than 2 days is the sort of the dark sort of petrol coloured dot. The light blue dot is 2 days to less than 3 days worth of antibiotics post procedure, and the orange dot is greater than 3 days. And so the 4 graphs there are cardiac surgery, orthopedic surgery, colorectal surgery, which, remember I said at the start of the talk, is very high risk for infection, and vascular surgery. And you can see that there is no statistically significant difference in any of the durations of therapy. So 24 to less than 48 hours of therapy is as good as 2 to 3 or greater than 3 days of antibiotic prophylaxis in all cases. What is not the same, however, is your risk of antibiotic-associated harms. So these 3 graphs here use the same time frames. So petrol is 1 to less than 2 days, blue is 2 to less than 3 days, and orange is greater than 3 days worth of antibiotics post-procedure. And you can see that the first graph is your risk of acute kidney injury following cardiac surgery, and that there's the suggestion of an exponential but slow exponential increase in your risk of acute kidney injury post cardiac surgery. For non-cardiac surgery, the acute kidney injury risk is less sort of clear, but still is significant. And the graph on the right shows your risk of getting Clostridioides difficile infection after any surgery. And you can see that you increase your risk by almost 4 times by giving a patient greater than 3 days of antibiotics. So, other than the fact that this is a great study and that it shows the results very clearly and that it was published in a surgical journal, the critical finding of this study is that not only do post-procedural extended courses of antibiotics not prevent any infections, but they actively cause harm. And for those of you who have also listened to my infection control lecture, the principle of healthcare infection prevention is to avoid harm from the healthcare that we're providing. And so extended durations of antibiotics are given with the aim to prevent infection, which they don't do, at the cost of causing harm, which we can see from these graphs that they do. That doesn't unfortunately mean that the surgeons have entirely come on board with not giving routine long post surgical courses of antibiotics, but it's a work in progress. So what are the components of a stewardship program? So as I've said before, education, decision support, which can be things like sort of flow charts and guidelines, protocols, the management of the formulary, which I'll talk a little bit more about, and post-prescription review. In a large survey of medical students, only around 1 in 3 of them rate their antibiotic knowledge to be adequate at graduation from uni. And certainly as someone who works on an infectious diseases team, when the students and in fact the interns and residents come and work with our team, you say, what is the thing that you would like to get out of this term? They invariably, and I mean absolutely invariably, always say, I don't know as much as I would like to know about antibiotics. I'd really like to learn everything. And this carries through into later clinical practice, not only a lack of understanding of antibiotics, but also a lack of understanding about what patients think about antibiotics. Now, this is also a relatively complicated study finding, so I'll try and go through it slowly. If you go and ask a random selection of general practice patients, if you go to the hospital and you have a sore throat, a runny nose, sneezing, and a general feeling of sort of malaise, so typical symptoms of a viral or upper respiratory tract infection, do you think you need antibiotics? About half of those patients, when given that list of symptoms, will say, yes, I think I need antibiotics. Now, if you go and talk to general practitioners and say, what proportion of your patients with a typical viral upper respiratory tract syndrome will want you to give them antibiotics, the GPs say it's about 2/3. And we know that in clinical practice, the rate of leaving the consult for your upper respiratory tract infection with antibiotics is much closer to what the GPs think than what the patients think. So the GPs think that almost twice as many people want antibiotics as actually do in real life, and almost 2/3 of them leave with a script. So we overestimate patients' desire for antibiotics, and we impose our sort of mistaken belief on them and on the system. And obviously I can't go into all the issues about prescribing in general practice, but the time pressure and the lack of ability to do good risk counselling and good sort of health promotion in a 6-minute GP consult in primary care is really very difficult. And so part of the other problem is that there's very limited understanding by the general public about what a problem drug resistance is. And I need to get back to work, and if I take antibiotics, it's probably, they're quite safe, aren't they? The doctors wouldn't give me something that's unsafe, and maybe it won't work, but maybe it'll get me back to work a day earlier, or get my kids back to daycare so I can go back to work, and that'll solve the problem. But on top of that, there's also, there's very, very little understanding of drug resistance in general. Patients think that, if you like, they become resistant to the antibiotics. It's kind of like an immune thing. I've been exposed to antibiotics before, and now I've developed an immunity, so now I have drug resistance, which is sort of similar to how it works. The bowel flora develop the resistance, and then the patient gets infection from those bowel flora. But there's a fundamental misunderstanding of the process of drug resistance. So this is my other favourite drug resistance study. It's by the UK's Wellcome Trust, and you can see the link to the report down there. They did public focus groups in the UK of just unselected random members of the UK general public, and they were asked a whole range of questions about drug resistance, about antibiotic stewardship, and all things on this sort of general topic. There was absolutely not one single member of the UK general public that was studied who knew what the acronym AMR meant. There was very, very little knowledge of what antimicrobial resistance meant, which is why you'll notice through this talk I've been trying to use the term drug resistance rather than antimicrobial resistance, because it's much better understood by the public. Antibiotic resistance fares a little bit better, but much to the despair of those of us who work in the area, the term with the most cut through was superbugs, which again I don't like, but is sort of what people understand. And the other interesting finding from this study is that all of those findings from the O'Neill report that I mentioned way back at the start of the talk, about billions of lives and trillions of dollars and all that sort of stuff, just doesn't cut through with the public. They just go, it can't possibly be that big of a problem, or they're just over-egging it because they want research funding, or there's something else. It's just an unimaginably large number, so it can't possibly be right. And so by quoting these ridiculous big nums at people, you just turn them off, and they're no longer thinking that it's actually a real problem. So the way that we communicate drug resistance to the public is, I guess, hamstringing us from encouraging them to use antibiotics more responsibly, because we're not communicating the problem in a way that is absorbed. The key recommendations from the Reframing Resistance report is that, essentially these 5, you can see them on the slide there. So we need to frame the message that drug resistance is undermining modern medicine, and it's doing it right now. And so that is, like I showed you back at the start of the talk, chemotherapy is becoming impossible because of the rate of drug resistance. You need to explain the fundamentals succinctly. The more antibiotic you use, the more likely you will have resistant bugs living in you that might make you sick in the future. We need to explain that it's a universal issue, that it affects everybody. It's not just people in the developing world. It's not just chemotherapy patients in tertiary centres of excellence in metro, large metro hospitals. It affects everybody. It will affect your Aunt Betty when she goes in to have her hip replacement next month. It will affect your sister who gets recurrent UTIs when she can't be treated with tablets and has to go into hospital for a fortnight to receive antibiotics through a drip. And these relatable examples are much more meaningful than, billions of people will die. We need to focus on the here and now. I have seen patients with untreatable urinary tract infections in my clinical practice this year. Not talk about what's going to happen in 2050 and how it's going to affect billions of people. It's a problem now, and because it's a problem now, we need to do something about it now. And what you can do about it now is not ask your GP for antibiotics. If your GP tries to give you antibiotics, you say, do I really need these, doctor? Is there something else that I can do? And so by giving people a concrete thing that they can do, rather than just remember about drug resistance and AMR and it's going to kill everybody in 2050, you're much more likely to get the message across and to encourage people to change their behaviours. Moving on from education now to guidelines. So we know that prescribers don't like following guidelines for the reasons that I said before, mainly that their patients are special. There's also challenging issues that ID physicians who are involved in writing the guidelines are seen not to understand our patients because they're just ID physicians and all they care about is drug resistance. They don't know how special and different and precious my patients are. But the thing is that people don't like following guidelines. They actually like writing guidelines even less. So that's part of the reason that we end up getting involved. What we do know is that if you involve the specialty clinicians in writing guidelines, they're actually more likely to follow them because there's that sort of engagement and that investment in the guidelines, and because they see that they've had some input into the development rather than them just being imposed by fiat by the infection control team. It's also a really good reason to get the specialty teams to write the guidelines because you don't want to, as the stewardship doctor, you don't want to have to be the person who writes every guideline in the hospital. Formulary restriction is part of stewardship. It's not just about locking up the meropenem. We know that formulary restriction is actually more effective, at least in the short term, than what we describe stewardship interventions as either enabling, so education and direct feedback, or restrictive, so locking up the drugs or modifying the formulary or requiring pre-approval. Restrictive interventions are more effective in the short term than enabling interventions. That's not surprising. But if you apply them both together, it improves the long-term prescribing patterns in your hospital much better than doing either alone. As I said before, there's little evidence of harm. There's really only one study that showed any convincing harms from formulary restriction, which was in Scotland, where they moved to Fluclox and Genta instead of ceftriaxone and piperacillin tazobactam. That showed an increase in the rate of acute kidney injuries in patients presenting through their emergency department. But that's the only study that I'm aware of that showed any significant harms from a stewardship program. And formulary restriction is much more useful if you do it as as a targeted response rather than just sort of a broad spectrum, locking up all of the things. And so the C. diff example that I showed before involved restricting antibiotics that were particularly high risk at causing C. diff. Some of you might be aware that there was a global shortage of piperacillin tazobactam a few years ago, and that allowed us to, rapidly implement a formulary change that conserved PIP-Taz for the people who really needed it. So the nuts and bolts of stewardship is the post-prescription review, or the stewardship round. So it's paper-based. We generally don't talk to patients, but we review their drug chart. We have a look at their hospital record, whether that be on paper or on computer. We review their pathology results and see whether the prescribing is consistent with what we infer the reasons for the prescribing to be from the notes and with the pathology that may or may not have been collected. And on the basis of that, we provide directed feedback to the prescribers. Hey, this guy is still on IV PIP-Taz when he's been in hospital for 5 days. His urine showed that he had an ampicillin-sensitive E. coli. I can see from the nursing notes that he's eating and drinking. So have you thought about sending him home on oral amoxicillin? It's also more likely, particularly for the junior doctors, to be taken up because it's patient-centered advice. It's, hey, you should put people on oral antibiotics as a general principle, versus Mr. Smith in bed 2 is eating breakfast so he can swallow amoxil capsules. And it's also a great opportunity to do opportunistic education. So while you're talking to the orthopedic interns about Mr. Jones and his catheter-associated UTI, you can also say, hey, the things that we can do to reduce catheter-associated UTIs are this, that, and the other. And it turns into like a mini teaching round. We try to do, I guess, a triage approach. So the ward pharmacist this is how it works in our hospital at least, the ward pharmacist who has the day-to-day contact both with the patients and also with the junior doctors provides the advice first. That advice generally gets ignored. So the stewardship pharmacist then tries again, says, hey, have you thought about doing what the ward pharmacist said and stopping the antibiotics? And the interns will say, oh, well, I'll speak to my registrar about it. And the registrar goes, stupid pharmacist, we don't care what they say. Because doctors tend not to listen to allied health professionals, unfortunately. And so then the infectious diseases registrar says exactly the same thing that the two pharmacists have said, and then the orthopedic surgeons go, oh, okay, well, maybe we'll do that then, but they probably don't. And then if there's a need and it's still going on, then when the ID consultant comes around, does a ward round, says, I really think you should do what the two pharmacists and my junior said, then they go, oh, okay, we'll do that then. That's who is providing the feedback. The provision of the feedback starts off with the prescriber, so the junior doctor. Again, that's their important targets for the opportunistic education. Then, if you don't get any sort of behaviour change, you go and speak to the registrar because they're probably the ones making the decision, just telling the juniors what to do. And if there's a significant issue and you think that there's a risk to patient safety, or there's been an egregious prescribing issue, then the ID consultant can speak to the treating consultant of the patient. As I said before, interventions that include feedback are much, much more effective. So it's entirely possible in the era of electronic medical records to do this stewardship round from your office. You just sit there, you look at what the patient's being prescribed, you read the notes, you leave a stewardship note in the chart, and then people don't read the note and then nothing happens. But the benefit of being up on the ward is that you can provide in-person feedback, you can provide some of this opportunity in education, and it's much more likely to be followed. Just a brief note on, hospital culture, if you like, as a major factor for driving antibiotic use. There's been a lot of work done by Alex and Jennifer Broome. So Jennifer Broome is an infectious diseases physician from the Sunshine Coast, and her brother Alex is a sociologist. And the two of them have done a lot of work on factors that influence prescribing outside of clinical stuff. And so it sort of boils down to risk. And so that is clinical risk and the risk of uncertainty. So I don't know what this patient's got. I don't want to get it wrong as a driver of prescribing. The fear of risk, particularly in terms of adverse clinical outcomes. So what if I don't give this patient antibiotics and they die? And also, what if I don't give this patient antibiotics, they die, and then everyone says, why didn't you give that patient antibiotics? So that's clinical risk to the patient, but also what's perceived as a reputational risk to the prescriber. And one of the other factors that risk plays into is this perception amongst prescribers that resistance is such a big problem that surely this one particular script that they're giving is unlikely to result in catastrophic resistance. And my prescribing, so there's the sort of my prescribing isn't, is a drop in the ocean and isn't going to do anything. But then there's also the balancing, well, I understand and I might want to prescribe well, but if I don't give the patient broad spectrum therapy, the patient might die. And so it's that sort of balancing of individual and public health risk. Relationships are crucial, and so that's within the treating team. So junior doctors do what their registrars say because they're anxious about not knowing what's going on. They do what their boss wants because they want to get a good reference at the end of the term and because they really, really want to get on the surgical training program. And if they're seen to be back-chatting their bosses, then they won't get a good reference and, blah, blah, blah. And relationship across disciplines are really important as well. What I was saying before about the involvement of teams in the guidelines and the perception that stewardship doctors are just, bossy bootses who, are interfering with clinical management. And so that means that if you're working in drug resistance and in stewardship, you have to pay very, very close attention to how you're getting on with the other teams, because if the treating teams don't like you and think you're just the antibiotic Nazis, which is something that I've actually been called by a surgeon, they won't follow your advice. And then there's also institutional variation. So what happens in big city hospitals is different to what happens in regional hospitals, which is what's different to happen in the bush, and not always necessarily in the ways that you might think. So, big city hospitals think that their patients are special because they're a big city hospital who does complex special medicine that all those people out in the sticks couldn't possibly understand. And people who work in very remote areas say, oh, well, you don't understand what it's like working in an area where we don't have a CT scanner and access to investigation. So it's a very complex sort of it again sort of feeds into that, oh, everyone thinks they're special kind of argument. And then finally, public and private is a very big issue as well. It's much more difficult to put prescribing guidelines in place in private hospitals because doctors there are essentially individual contractors and aren't really bound to particularly follow institutional protocols. And if the private hospitals are too bolshy about trying to restrict their clinical practice, they'll say, oh, well, piss off, I'm going to go to the other private hospital down the road. So it's much more difficult to institute good prescribing guidelines in private hospitals. And that's before the fact that you get into the issue that running a stewardship program in a private hospital is potentially a conflict of interest. Hey, I'm only going to let you use meropenem if you ask me to see the patient for which I receive remuneration from Medicare. Creates a very significant conflict of interest. That is a challenge for infectious diseases physicians in private hospitals. So just a few slides at the end to wrap up some of the public health issues. So why is drug-resistant infection a public health issue? Well, the flippant answer is, well, duh, resistant germs, longer in hospital, morbidity and mortality, all that sort of stuff. Well, obviously it is a population health issue, but why is it something that public health practitioners should be taking seriously? Well, unfortunately, there's a lot of siloing in healthcare. This will come as no surprise to you if you have worked in the health system at all ever. And the siloing also extends to the management of drug resistance. So population health, so public health units, don't think drug resistance is a public health issue. They think it's a clinical issue and that therefore it should be clinicians, so ID physicians, who should sort it out. Now, that's being perhaps a little bit unfair to my public health physician colleagues, because many of them have said to me, oh, look, Trent, we absolutely agree that drug resistance is an important population health issue, but we're just not the right people to manage it. So it's not that they don't consider that it's a problem, it's just that it's seen as not inside their wheelhouse. The other thing is that the tools that public health units have to respond, and this is especially an issue in Queensland where the population health units really were stripped out of any health promotion or any preventive health sort of resources back in 2012, that the sort of communicable disease control model that public health units employ, so case identification, screening of close contacts, ring fence vaccination, or mosquito control interventions to prevent spread, just doesn't work for drug resistance because it spreads more slowly. It's carried by individuals for longer, and the question is, how do we apply the tools that public health have to the prevention of drug resistance? And the answer really isn't in a health protection model; it's much more in a health promotion model. And, obviously, as well, as I've said, the increased costs and healthcare utilisation associated with drug-resistant infection is very much an equity issue, which is something that sort of public health is should well and truly be aware of. Looking at that in a slightly different angle, there was this great study by Baker and colleagues in New Zealand back in 2012, which looked at the very significant proportion of healthcare utilisation that was associated with infection. Now, they used a very broad definition of infection. So, for example, stomach ulcers were considered to be largely infectious because of the association with H. pylori. Cervical cancer was considered to be an infectious issue because of the association with HPV. So, broad definition of infection. But acknowledging that limitation, 26% of admissions to New Zealand hospitals between 2004 and 2008 were associated in some way with infection. The Queensland Health Statistical Services branch did a similar analysis in Queensland and found that 9% of hospital separations in the 13-14 financial year were infection related, and some work that I did in Cairns found that 13% of separations in our hospital between 2009 and 2014 were related to infection. Now, the other thing that makes it particularly important from a population health point of view is that you can see in the graph on the right and the last few dot points that there is a much higher rate of admission for an infection-related diagnosis if you live in remote or very remote Queensland. I haven't shown the graphs, but also the graph for socioeconomic status is basically the same. So the most disadvantaged individuals in Queensland have the highest rates of admission with infection, and the lines for Indigenous versus non-Indigenous Australians look basically the same as the high 2 lines versus the low 3 lines on a graph. So there's a disproportionate effect from infection on people who are remote living, socioeconomically disadvantaged, or of culturally and linguistically diverse background. So you're more likely to get an infection. Other work that my team and other places have done since then have shown that in fact some remote and regional areas of Queensland have much higher rates of resistance. So not only are you more likely to get an infection, but you're more likely to have a resistant infection, and therefore the inequities of being disadvantaged and poor and remote living and culturally and linguistically diverse are compounded by the prevalence of resistance in these areas. So I think there's absolutely a role for public health thinking in the management of drug resistance. Many of the recommendations from the O'Neill report rely on community education, on global surveillance, on development and uptake of vaccines and other infection prevention methods, which are things that public health training is very good for guiding and implementing. And because we've really failed thus far to adequately communicate the risk of drug-resistant infection to the community, and obviously that's something that population health practitioners are much better at than clinicians by and large. Finally, just something else to think of in terms of reframing drug resistance in our heads. As I said before, we typically apply either a clinical model or a communicable disease model to drug-resistant infection because that's the model that we're used to thinking of. However, if you think about drug resistance, it may be persistent or long-lasting. We know that if you take a course of antibiotics, you can find resistance determinants in people's bowel flora for many months afterwards. Similarly, if you go traveling to India or Pakistan, places that have got very high rates of resistance, then you can carry that resistance in your gut flora for many months after you return. It's strongly affected by environmental and social factors, as I've just said. So your likelihood of acquiring a resistant organism from travel, from where you live. It's strongly affected by socioeconomic status and other sociocultural determinants. It's very strongly affected by health behaviours, both of patients. Do they go to the doctor? Do they have lots of health-seeking behaviour? Are they hospitalised a lot? Also, the health behaviours of prescribers. Am I going to give you antibiotics when you may or may not necessarily need them? And it also probably, and I haven't touched on this today, is affected by biomedical factors. Like there's increasing understanding now that the number of antibiotics you get exposed to as a child may have lifelong effects on the makeup of your intestinal microbiome, which may increase your propensity for getting resistance. It may also increase your risk of getting chronic disease and other issues. And finally, that resistance, as it's carried for a long time, may result in long-lasting health effects over time. So depends on which units you've done in your public health study so far, but these are the key factors that identify what public health physicians consider to fit under the chronic disease model. So we need to apply chronic disease thinking to drug resistance much more, I think, than communicable disease thinking. So finally, I'd just like to reiterate again that drug resistance is a huge threat to healthcare and that it continues to become more of a threat every day. That every single dose of antibiotic causes resistance and that we need to apply a risk-benefit analysis to the use of antibiotics much more rigorously than we do. Preventing infection is preventing resistance, and that everything we can do to prevent infections through sanitation and development, through vaccination, through infection control, and better diagnosis of infections and earlier treatment prevents resistance as well as preventing infection. When infections do occur, take samples, follow guidelines, review prescriptions as much as you can, take IV lines out. And remember that stewardship is about providing better care to individual patients as well as improving community outcomes.